Thank you for the opportunity to present. Sorry, let me just go back. Yeah, so I'm presenting these results on behalf of the EPIC network. So we're moving from the trial setting to the real world setting. So this is looking at young children, infants and children under 12 at start of Dolutegravir in routine care in Europe and Thailand. Okay, so this study was funded by ViiV Healthcare. So as you'll be very familiar with, so Dolutegravir is recommended as the preferred first and subsequent line treatments since 2018. But we also know that pediatric Dolutegravir approvals were staggered over time for the different age groups, first approved for the adolescents, and then extended to those over 6 years, and most recently to those over 4 weeks. And this generally results in less data available on the medium to long-term outcomes of the younger age groups receiving this drug. There are emerging data coming out from observational studies of children and adolescents in routine care, which have reported reassuringly low incidence of viral failure, be it defined as viral load over 400 copies or 1,000 copies by 2 years on Dolutegravir. It's ranging at around the 4% mark when looking at large cohorts which have been reported from Lesotho, Uganda, and also in our own previous analyses. But many of these studies were largely dominated by adolescents who contribute the largest proportion of the population. Interestingly, across all of these studies, maybe as we would expect, they have reported higher risk of viral failure among those who are ART experienced and viremic at time of Dolutegravir start. And there's been some studies showing increased risk among the older age groups. In general, there's been less data and certainly less disaggregated data looking at the medium to long-term outcomes in the younger age groups under 12. And therefore, that's the aim of this study. So this is an overview of our EPIC cohort collaboration. We've recently been renamed from the European Cohort Collaboration to Epidemiology of Pregnancy and Pediatric Infections International Cohort Collaboration. We regularly pool individual level data with complete clinical and treatment history of children and adolescents in routine HIV care. In this study, we included 15 cohorts across 14 countries shown here, some of which are national cohorts. The inclusion criteria for this analysis was age under 12 at start of Dolutegravir, and the data was cut off at October 2024. Oops, let's go back. In terms of effectiveness, we're reporting the proportions who are virally suppressed under the 50 copies threshold at 24-week intervals up to 192 weeks after start of Dolutegravir. We'll report the cumulative incidence of viral failure, which was defined as confirmed failure having 2 consecutive viral loads over 400 copies after 24 weeks on Dolutegravir, or an unconfirmed viral load of over 400 copies followed by DTG discontinuation within a 4-month period. We're reporting the outcomes overall and also by their ART and viral load status at start of Dolutegravir presented in these 4 groups: those who are ART naive, those who are ART experienced and viremic at over 200 copies, those who are ART experienced and already virally suppressed under the 200 copies to allow for some low-level blips, and then those who are ART experienced but did not have a viral load around the period of Dolutegravir start. In terms of safety, we're reporting the frequency of adverse events and serious adverse events which were reported by the clinician as causally related to Dolutegravir, as well as all SAEs irrespective of their relationship to DTG. A lot of these children also received routine laboratory monitoring, and so we're able to report the frequency of DAIDS grade 3 and 4 events, and also looked at some rates of over 1 grade event per 100 person years. We report the frequency of discontinuation of Dolutegravir and the cumulative incidence over time, including all cause of discontinuation. So the data is censored at the last visit, death, or discontinuation of Dolutegravir, for most outcomes except for safety, where it's at discontinuation plus 30 days. So here are the results. We have data on 535 children, included here Approximately half were female. The median age at start of dolutegravir was 9 years. We had about 20% who were aged under 6. And here are the distribution in terms of ethnicity and region. On the right-hand side, if I can draw your attention to the ART and viral load status at start of dolutegravir, so 13% were ART naive, 12% were ART experienced and viremic, and the majority, almost half, were ART experienced and already suppressed at start of dolutegravir, so the transitioning group. And then about a third were ART experienced with unknown viral load. Among those who were ART experienced, the median duration on ART was 7 years, had a relatively high CD4 of 34% in the median, and over 800 cells. In terms of the median duration on dolutegravir, this was 114 weeks at the data cutoff. So this is the overall picture in terms of viral suppression under 50 copies. It was consistently over 80% at each time point. So at the 96 weeks time point, 90% were virally suppressed and increased to 93 among those on DTG at 144 weeks. And at the 192 weeks, among those who had that length of follow-up, it actually reached the 95% UNAIDS target, which is fantastic to see. And when we compared it among those who were under and over 6 years of age at start of dolutegravir, we saw that there were comparable results. However, when we look at the viral suppression according to the ART and viral load status at dolutegravir start, we do see a slightly mixed picture. So you see so the black line is the overall proportion suppressed in the entire cohort, and then this is based by ART and viral load status. You see the highest performers, let's say, those with the highest level of viral load were those who are ART experienced and already suppressed at the start of dolutegravir, so those maintaining sustained, generally, suppression. A slightly different picture among those who are ART naive and lower levels of viral suppression, particularly among those ART experienced and viremic, and this difference at 96 weeks was significant. In terms of the cumulative incidence of viral failure, we had a total of 23 children who met that definition of failure. Cumulative risk of failure was 4% by 96 weeks and 7% by 144 weeks overall. But again, significantly different according to the ART and viral load status at DTG start. So by 96 weeks, this was 15% among those ART experienced and viremic at start of dolutegravir, and among those who were naive, it had an 8% viral failure rates and much lower levels in the already suppressed group. In terms of safety, we had relatively few events, so a total of 13 children experienced 18 adverse events reported to be causally related to DTG, including 1 SAE. Most of these were laboratory abnormalities, or there were 5 children with neurological or neuropsychiatric related adverse events. Overall, there were 5 SAEs, there were no deaths, 1 possibly related to DTG. In terms of laboratory data, this was available for most of the children, and about 4% experienced at least one DAIDS 3 or 4 event, and this was under 1 event per 100 person years. 53 children discontinued dolutegravir. There's a cumulative incidence of 6% discontinuation by 96 weeks and 10% at 144 weeks. So in conclusion, we believe this is one of the largest studies to date to provide detailed outcomes on dolutegravir in children in routine care who are under 12. Overall, dolutegravir was well tolerated with a low number of adverse events and discontinuations. In the overall picture, the levels of viral suppression was very high, well over 80% at all time points on dolutegravir. Low overall incidence of viral failure by 96 weeks, but this was markedly higher in those who were ART naive and ART experienced and viremic. These findings were very comparable to our previous analysis, where most of the population included were adolescents, so very similar trends. I think in terms of further monitoring and targeted support, this particularly would perhaps benefit those who are ART experienced and viremic at start of dolutegravir, who appear to be at highest risk. And just to note, the Odyssey trial did report recently a very nice paper showing that among the children who experienced viral failure on dolutegravir-based second-line ART, 19% of those did develop INSTI resistance. So it'll be interesting to see what we might gather from the real-world setting. There are ongoing analyses with our data on outcomes following viral failure, and this will be important in informing future management strategies. And if you haven't had a chance already, just to flag, there are a couple of posters potentially of interest. Kate Edgar has been presenting on growth on children in this cohort, and we also have our collaborators, Ellen and Magonga, who presented similar analysis on viral failure of children on Dolutegravir in Uganda. So thank you to all of our contributing cohorts, the children and their families, and our funder. And as a final plug, if I may, this is the Capacity Strengthening Hub, which is a free resource that our unit has been developing over a number of years. It's on the Global Health Network. It's free to use. Just submit, and we have lots of recorded trainings. There's a very nice LMIC mentoring program. So in case of interest for the people here. Thank you.
Thank you, Jeannie.